Good afternoon, everybody. It's great to have you all here. I think we have people still joining, and so we'll give it just a minute, but welcome to the CFHA PED SIG. I'm Matthew Tolliver. I'm one of our co-chairs, and Rachel Petz is also on. She's one of our research leads, and it's part of our leadership team. This whole year, we've been focused on the pediatric mental health crisis and how do we respond to that and what do we do about it. And we did an extended learning opportunity at the conference at CFHA in October and talked about the Surgeon General report that came out last year and those recommendations and how we as a community can respond to that and kind of create an action plan from that. And I think we saw some of you all there, and it was great to see you, and I hope you had a good conference if you went to it. Today, we wanted to talk some about the new recommendations that came out from the U.S. Preventive Services Task Force. And so the way that our meeting is structured usually is that we have kind of this little intro time where we want one of the purposes of this to be kind of a networking opportunity for you. So, you know, if you're just calling in or if you're doing something else and have your camera off, that's totally fine. If you want to turn your camera on, that's fine too. We're a pretty casual group. Feel free to eat and be on the call at the same time, since for a lot of you, it's over lunch. And if you wouldn't mind, just you can introduce yourself in the chat. You can, maybe put what your role is and where you're coming from. And that gives everybody an opportunity just to see who else is on the call. And a lot of this can, if you've got particular questions or concerns, it's probably questions other people have too. So you can kind of network behind the scenes as needed. The other thing that we do is if you have job opportunities that you want to advertise, you can also put those in the chat. It's kind of be another way if you've got postdocs or other positions you're recruiting for, another way to get that word out there. Kind of like the U.S. Preventive Services Task Force recommendations, we'll have a little bit of a research corner about it where we'll get a little bit more in-depth into that topic and from the literature perspective. And then we'll have a facilitated discussion around that particular topic. And that's really designed to be less of us doing a big didactic to you, but like you coming and bringing your impressions, your questions. We want it to be an active conversation where everybody feels like they can jump in and chime in. And then some months too, we have a kind of this is how we do it little section where somebody will present about how they do pediatric integrated care in their position. And so if you are interested in highlighting your organization or what you do, we would welcome you to shoot us an email, anybody on the leadership team, and we can get you scheduled a month to just do a little 5-minute presentation. It doesn't even have to have slides or anything about just how you do integrated care and what your role is in your organization. So we get a broad kind of representation from everybody from what we're all doing. We've got a lot of clinicians, researchers, directors of behavioral health, people that join the SIG and join this call. And so we want to be open and responsive to everybody's needs. All right, so Chus is the other co-chair, and she'll be joining us in just a little bit. But the other housekeeping thing that I wanted to do before we kind of get into the content is talk about our kind of elections that are coming up every year. There are certain positions that are kind of become open that if you want to be part of our leadership team, then we would do some voting related to that over the next month. Rachel Petz, who I was talking about before, has applied to be in the running for the co-chair position for next year. So I wanted to give her just a minute to tell a little bit about herself and who she is and why she's running. And then I'll tell you a little bit more about other positions that we could advertise for. And Shus, if you have the PowerPoint, I guess, for any of those positions, we could share that too. But I'll let you take it away, Rachel.
Sure. Thank you. Hi, everyone. Rachel Putz. Great to see everybody. So just a little bit about myself. I'm currently an assistant professor in the clinical psychology doctoral program at Fairleigh Dickinson University in Teaneck, New Jersey. And in this role, I guess I have kind of two important hats that I wear related to integrated care. And so one is related to research and program evaluation through my research lab. And I do a lot of work with community clinics, helping in terms of kind of evaluating the work that they're doing. And I also do some work related to delivering or kind of creating and evaluating brief interventions that can be transportable to primary care. So I do a lot of kind of research and program evaluation work. And another important aspect of my job is, or one thing that I'm hoping to kind of do a little bit more is to expose students to clinical training experiences and primary care. I was very lucky as a graduate student to have those experiences. It's really formative for me. I think kind of changed my trajectory. So I wear those two roles or those two hats in my current role at FDU. I'm really interested in this position. I've been part of the leadership team for 3 years now. I started as research lead in 2019. It's been a fantastic experience. I've overseen the development of the pediatric track certificate, which will be coming your way shortly for those of you who attended pediatric focused sessions at CFHA in October. And I've also, as you'll see briefly too, oversee research corners during the monthly member meeting. So basically finding kind of different research articles that pertain to the facilitated discussion. So today I'll be going over some of the task force recommendations and the research behind those recommendations. It's been a really kind of great opportunity to work with different individuals in pediatric primary care. I kind of felt like it's probably the next step for me to go up for co-chair. And so I'm really excited for this opportunity to serve in that capacity and appreciate you all for your consideration.
Yeah, thanks so much. Rachel's been an awesome part of our leadership team and excited that you're thinking about doing that. And then Jonathan Larson is somebody who was considering taking over for Rachel in the kind of this research lead position. So Jonathan, I wanted to give you a chance to just introduce yourself and tell a little bit about who you are.
Hi, everyone. I'm Jonathan Larson. I'm a fourth-year graduate student at Wichita State University in Kansas. I was previously in Dr. Petz's lab before she moved to schools. I'm a practicum student at CAPS, at Counseling and Preventive Services, basically college student crisis interventions. I recently was at the KU, University of Kansas pediatric clinical practicum. I now do an after-school program and research, a whole big team thing about, it's a really great study, basically the summer treatment program. It's now being adapted to an after-school program, which it has been done, but no research has yet to really evaluate that. So really excited for that opportunity. But anyway, I'm really passionate about research, and I'm here before all of you guys. I have a lot more experience and expertise than I do, but I think given my career goals, this would be an excellent opportunity. I would certainly try to live up to Rachel's previous research corners and deliver great PowerPoints, kind of reviewing the literature and summaries. But I've enjoyed, Rachel actually introduced me to CFHA and the PED SIG itself. So I'm grateful for that. It really is hard to get that opportunity as a graduate student. And something that I've been interested in is kind of promoting that. I worked with Jessica previously, who did most of the work, and basically trying to increase our membership. That's a goal I have as well. Anyway, thank you all. Nice meeting you.
Yeah, thanks, Jonathan. So if you're new, normally in the kind of October month, we recruit, hey, anybody interested in running for these positions, they submit a paragraph about who they are and why they want to run. And then in this November meeting, you give like a 1-minute spiel to understand who they are. And so with the co-chair position, there's 2 co-chairs and they kind of stagger a 2-year term. So I'm kind of rotating off at the end of this year. Chus is going to take kind of, she's been on this year and will continue next year. And so if there's no one else running, Rachel will kind of move into that other co-chair position. We wanted to just briefly, in case you're kind of thinking about the future a little bit of if you would want to be a part of the leadership team, just what these positions are and what the responsibilities are. And you're welcome to kind of back channel us if you have ideas or if you have other questions. But we have this co-chair position. There's 2 co-chairs, like we said, one will be replaced every year. And then we have this research lead position, which doesn't necessarily have to be even an elected position, but it's what Rachel and Jonathan were talking about, where you kind of do a little bit of research each month and present a research article around a topic that we're focused on. And then we have some membership and engagement person who really tries to bring everybody together, recruit new people into the organization, really tries to make sure what we're talking about is what's important to the members. And Jess from Geisinger has been that person this year. And I believe she's open to having a new person move into that role if anybody would be excited about something like that. And then we have a secretary position that Michelle is involved in. Michelle, I think you're here if you want to wave. Do you want to talk a little bit about the responsibilities for that position?
Sure, I can do that. Okay, for the secretary position, you have to attend the meetings. The main role is around taking minutes for the meeting and sending those out to the SIG, and then also sending out an agenda to remind everyone of the meeting and to give them an idea of what we're going to be talking about. And those are the main 2 pieces, are around, making sure that you're keeping the group organized and taking notes when you can.
Yes.
Yeah.
Thank you.
Yeah.
And then finally, we have a student representative. Jonathan is our student representative this year, but we are open to others. So if you are a student or a trainee, or a good one, then we are always looking for other people who can be a part of that leadership team. And so I wanted to share that because some of the people in their current positions, like secretary and membership and engagement, they're saying, hey, we're really open. If somebody else is excited about this and wants to do it, please message us and let us know. I think they may be willing to continue on next year if no one else is willing to do it. But usually we've kind of missed that deadline for people formally applying. But if you're like, oh my gosh, I got to do this, I really want to do it, then please message me and I'll put my email in the chat. And if you want to do that, probably letting me know this week would be important. And then we can talk more if that's something that you're interested in. All right. Any questions about the positions or the elections or how that works? All right. Well, I will turn it over to Rachel then to talk a little bit more about the topic that we all came here to talk about.
Thanks. I'm going to share my screen, so give me just a second to get the PowerPoint up. Okay, so I'm going to go over basically the Preventive Services Task Force recommendations related to depression and suicide risk. Now, if you were at our meeting in April, we did go over when they first initially kind of posted their recommendations. And so today is somewhat of a review of those recommendations, but they also, when they posted their recommendations, they left it open for public comment. And so they somewhat addressed some of the public comments. And so I'll talk a little bit about that. And I added in some pieces related to some practice considerations, which I think will hopefully kind of help us as we get into discussion today. So as it pertains to what did they recommend, their first recommendation is that if it is an adolescent age 12 to 18, we should be screened for major depressive disorder. They gave the grade of evidence for this as a B. It's moderate evidence supporting this recommendation. It is not an A, but it is better than insufficient, which is the I, as you see below. So for children 11 years or younger, they're concluding that there is insufficient evidence to balance the benefits and harms of screening for MDD. And they give the same recommendation as it pertains to screening for suicide risk in children and adolescents broadly. So I'll talk a little bit about their practice considerations related to that. It's important to dive into their rationale and evidence because I think for many of us, maybe scratching our heads in terms of why not for younger folks and why not doing kind of an overall screening for suicide. Basically, they're looking at detection, benefits of early detection intervention, and then harms of early detection and intervention, and essentially are concluding that, again, as I mentioned, there really isn't a lot of evidence on screening instruments, so screening particularly for children ages 11 and younger in primary care. But as we might know, there's a lot more evidence as it pertains to teens and MDD. So they felt pretty good about that. They're looking at direct or if there's any indirect evidence related to the benefits of early detection and intervention. And again, concluding that there's no direct evidence on the benefits of screening for MDD in children age 11 or younger. Inadequate evidence of the benefits of treatment in children who were screened and detected with MDD. As we kind of compare over to teenagers, while there's no direct evidence on the benefits of screening for MDD, on health outcomes particularly, we do have good evidence related to related to the benefit of treatment if you screen for MDD and treatment related to depression. So again, it's really just the weight of the evidence, which is not fully satisfying and suggests the need for more evidence, essentially. We don't have enough as it pertains to harms, but we do know, or feel pretty confident when it comes for teens, that there's no direct evidence on the harms for screening. And if there are any harms, or we're thinking that there's likely minimal harms, when it comes to treatment, particularly when it comes to psychosocial interventions. So this is how we get our assessment in terms of the recommendations. And suicide risk is very similar, that we don't have direct evidence in the benefits of screening, and as it pertains to potential harms, benefits. And so they just say we need more, essentially. They do highlight, because of the insufficient evidence, that we should be doing some more research in these settings, more RCTs, particularly for the younger kids, quality RCTs, basically extending kind of populations in terms of those who are typically not in our RCTs as it comes to kind of underserved populations. We know this too, that we need more evidence on integrated care and how that can be beneficial with screening and treatment. And for suicide risk, again, lots of information related to we need more as it pertains to screening, and that's a biggie. And of course, in terms of treatment and reaching people who would be best served by screening and intervention, or who may be at most risk for suicide. So here's kind of what's new that I wanted to highlight, because they got public comments and then they attempted to address them. So one of the things that they wanted to clarify is that none of the studies they reviewed reported on the potential harms of labeling, stigmatization, and over-medication that are hypothesized to potentially result from screening. So those would be the potential harms. We don't have any evidence that those harms are there, but that we can't rule those out. They found extra studies, a few other evidence, but it didn't really change their outcomes. They did provide a little bit more guidance as it pertains to screening in primary care. They focused specifically on collaborative care models, which we've discussed before in here, typically have the most evidence as they're easier to study. And we do know that there is more evidence on collaborative care in primary care versus other models of integrated care like primary care behavioral health. So they give some resources related to that. Apparently people probably gave some recommendations as it related to screening tools like for suicide. But the task force said that it too uncertain and didn't kind of reach maybe their we're unable to really kind of draw conclusions based upon the additional screening tools. So more research is needed. I think adding in practice considerations, things to kind of consider is important here. One thing that they make very clear is that the recommendation that they are giving only applies to those who've not been diagnosed mental health disorder or showing signs or symptoms of MDD or suicide risk. So these recommendations are really supposed to be broad screening measures. And of course, they kind of discuss in their recommendations that there may be certain individuals who may be more at risk for suicide, for instance, or depression, in which you may be using your clinical judgment here, but really these recommendations are broad-based screening for everyone and what we should be doing. Thought an important point to also highlight with the practice considerations, what they're recommending here is that they're focusing the screening for MDD only, and not dysthymia or other kind of depressive related presentations, I suppose. And so that's important to kind of keep in mind in terms of the research evidence, and most of the RCTs are just focusing purposefully on MDD. Although they did not find any potential harms per se, they did acknowledge that there could be harms of screening for young children, and that they kind of acknowledged that there could be false positives, you have unnecessary referrals, treatment labeling, and I think there's kind of the idea that there's some risk related to medication use, but psychological interventions would have minimal harms. So that's the update and their kind of recommendations in response to comment. And so I'll open it back up to the group, because I think we were really hoping to have a larger discussion about the implications and how people have been kind of implementing screening and treatment in practice.
Thanks so much, Rachel. I think that's good to kind of level set with everybody just what the recommendations are and some of the implications of that. And one of the conversations on the chat was just what screeners are being used or validated for kids under that age. And I wanted to throw that out back to you, Rachel, and then to the broader group too, if there are particular screeners. And it looks like Verna Little too has her hand raised. She might have something to contribute as well.
Hey, I'm going to stay off camera because I'm a little under the weather. So hello, everyone. Just one thought. I just wanted to level set because I'm not sure we did like why this is so important. I know Concert put in recommendations along with other friends on the call like Meadows and some others, but the inclusion of things in the task force not only encourages the field to do the screenings, but eliminates patient responsibility. Like this has such broad implications aside from recommendations in the field. So I just really wanted to clarify for people, which I'm not really sure a lot of people understand what it really means to be included in the preventive task force and sort of the much broader implications. And one of the things that we tried to do this time was to get them to expand on some of the language around what happens after you screen, which I think is really important. And if I would hope for this group to get motivated around something, it would be the next time there's public comments that we all, participate and try to expand because they didn't get it right. And hopefully we have some opportunity to change that.
Thank you. Can you talk a little bit more about what implications that you're referring to? For kind of it sounded like you were saying there's a lot of implications on just the practice level.
Yeah, well, so first of all, when things become recommended as preventative, they get added into training curriculums, they get covered by payers, they get adopted into provider manuals, there gets to be more publication and research around them, and excluding or eliminating any of the patient responsibility for screening costs is a huge factor, to really support screening. If you talk to, places where the Medicaid fee schedules don't cover it, or we're doing a national project now around commercial plans and the coverage of the 96127 code for screening in general, which includes the adolescents. And it's all over the map. So most of the providers don't do it because they actually can't figure out how to get paid for it. And so having it included here would be incredible. And so just those are some of the smaller, broader implications to think about.
Thank you for sharing that, because I think that is important to recognize that, okay, we have this recommendation, but on a broad level, what implications to just being a part of this level of recommendation entail in terms of training and reimbursement and policy. Anything else you wanted to add, Rachel?
I was looking at the chat, the question about like, are there even screeners for age under 11? It looks like maybe some people posted some ASQ, which I hadn't heard of, but I mean, I think that really is kind of the big issue. And I know in terms of when I was practicing in primary care, we didn't have a we didn't have a screener for under age 11, and typically you're just using PSQ. And so that's not necessarily a screener for suicide risk specifically, although it asked that question. So I think it just kind of points to the need to do more of this work.
Oh, I was muted. I was saying thank you so much. And I want to turn it over to my co-chair, Chus, to talk a little bit more about our facilitated discussion, or maybe Chus, if you have other questions that you want to throw out.
Thank you. I have so many. I don't know where to start. I appreciate Virna's comments to get a little bit of the insider view, although I still don't understand how this works, how this gets to be recommended or not. I mean, I understand Rachel did a wonderful overview of it, but I still don't get the logistics of how they decided, and against so many recommendations from professional associations like the AAP and others. But it is what it is. I'm just curious what people are using, and I also saw some in the chat. We use the ASQ for suicide, and we have it available in Epic. And I think what is important about that tool is also that it's a decision making, not only a screener, so it facilitates the next steps for the PCPs. Because one of the things that comes to mind for me is what next if some people don't have integrated behavioral health. So I don't know if people want to chime in about whether it's the instruments that they use or perhaps what are the workflows that they have in place, especially for the suicide one. There is a question about the ASQ. Are organizations allowed to use ASQ without paying? As far as I know, yes, but in my organization, I'm not connected to that part of it. So I don't want to misrepresent the truth. There are some people also chatting about the promise. Does anyone want to unmute and talk to us about that one?
Sure, I can if you want.
Thanks.
That's me. We use the just so you know, we actually, I know a lot of people are using the ASQ. We use QPR at UW Health, which is question, persuade, refer. And that's like a whole training system that trains anyone on how to assess and what to do with suicidal patients. So like everyone from our front desk staff to our nurses get trained on that.
Awesome.
And then we at UW Health use the Promise. It's a very brief and ultra brief kind of screener. It's 8 questions, and it's also in the public domain, and it's for ages 6 to 12. And it looks at essentially, there's a depression version and an anxiety version. And there's a parent proxy version and a child version. So the child version is for 8 and up, and the parent proxy is for younger kids and older kids. You can do it for both. And that looks at, there's a depression version and an anxiety version. So it looks at depression symptoms in the depression one and anxiety symptoms in the anxiety one. And it was created by APA, the American Psychiatric Association. And so it's newer. This is the second version that they've done. I'm actually curious to know if anyone else is using it, because we have been using it. It's been a really useful tool in terms of like screening for those symptoms, but it doesn't specifically look at like suicidality.
Thanks so much. And anyone else is using the Promise? Or anything else?
This is Rick Gross from Sadler Health in Carlisle, Pennsylvania. I'm off camera. Sorry, I am eating and I feel bad that I don't want people to watch me eat. But I guess my question is, we've been doing screenings for 12 and over. I'm at an FQHC. So we've been doing screenings for 12 and over, just using really the PHQA. The QPR thing is very interesting to me. I'm kind of Googling it as Shauna was talking about it. I guess I find myself wondering, we have so limited resources in our area. I'm sure we're not alone. I'm sure there are lots of people out there who have similar situations. I don't have very much to refer to in terms of getting somebody immediate help, right? So the QPR is great. I just don't know. I don't have anyone to refer to. Hey, oh, you're going to see this person tomorrow or the next day, or even the day after that. It's going to be 6 weeks or 8 weeks. And I wonder how people are managing that challenge. I mean, I can do some safety planning. I don't know the research around that kind of stuff, but I'd love to hear other people's thoughts about that.
And Rick, I assume you are medical practitioner because of the comment you made when you said you don't have anyone to refer. What's your role in the practice?
Yeah, my apologies. I should have specified. I'm a BHS, and we use a PCBH model.
Yeah, thanks.
So to be clear, in the QPR, the refer is like, do they need to go to the ED or not? It's not like you're gonna see someone tomorrow necessarily. Like that's, you can do that, but you know, like for us, it's like, do you need to see your primary care doc right now so they can, or do we need to send you to the ER right now? So I don't think you necessarily have to have someone on call. It's more so like a way to get folks comfortable with asking those kinds of questions.
So as for next steps, following Rick's question, what are people doing when they use this type of screening?
Yeah, with QPR, like I just mentioned, what we do is we send either people directly to their doc if they are in-house, or directly to the ER if they're at high risk.
We use
Do
the
you- go ahead.
and send, and it's similar to the ASQ, has different guidelines based off of what people answer and what level of risk they're at, and we'll either send to the emergency department or schedule follow-up with PCP or a behavioral health consultant.
So who does the safety planning following the screener before, if the situation is such that you're not sending to any crisis assessment or the ER?
The medical provider, or they do a warm handoff with a behavioral health consultant.
Mm-hmm. So you train your medical providers on the safety planning?
Yes. We have both the Stanley Brown safety plan, which we just got some free things from SAMHSA. I ordered, like they sent us a bunch of these like free like Stanley Brown like little packets that we just have in the adolescent rooms now, that you can just fill them out on paper and hand them to the adolescent. And we also have the emotional fire safety plan that our providers are trained on.
Mm-hmm. And Rick, I know you were asking the question of what next. What are the steps that you, as in the PCBH model, take after you screen for suicide, or if you were to screen for suicide? I guess what I'm asking is about the intermediate steps, or the steps people are taking when they don't take the big step of doing something outside of your teams.
For us at ETSU, the BHCs will do some safety planning, and then we try to do some sort of values-based behavioral activation brief intervention, or really like kind of a functional assessment of that, right? And like what's really driving this for that particular kid, and let's start to figure out how to help with that, right? And maybe it's dealing with a family dynamic issue, maybe it's a school issue, and really start to try to do treatment in that moment, and then we'll see them back. We had talked, I think, a couple months ago about this like feeling of this like bridge to nowhere, where we're like, we'll just see people until they get connected to special mental health, and then because these teenagers or these kids really need it, but for a lot of people that's not, like, either they don't go, or they don't get connected, or it's a super long wait list, or it's just not acceptable to the family. For some people it is, and for that it's great, but I think we try to work a lot and follow some of that GLAD PC guidelines for treating adolescent depression in primary care, and working with the pediatrician, and sometimes we'll see them several times until they're a little bit more stabilized. Sometimes we do try to get them referred out. Recently we've embedded kind of in a stepped care model an outpatient therapist into our clinic. So we have like PCBH level BHCs, and then we have kind of one tier above that in terms of above, meaning like just a little bit more long-term therapy looking. And we also have tried to meet with our local mobile crisis administrators to start to streamline some of those pathways to prevent kids from having to go to the ER, and actually be able to go to some other either kind of non-ER based mobile crisis assessment points, or doing some Zoom based mobile crisis evaluation from our clinic for the kids who do need that kind of maybe inpatient level of help.
Hi, I'm at an FQHC in New Jersey, and somewhat similar to Matt. We do the BH providers will get involved. We screen with the PHQA. The BH providers will get involved to do crisis assessments and safety planning if they don't need to go to the ER. We are lucky that we have a team of case managers who also assist us. So sometimes our case managers will take it from there to link to. In New Jersey, we have the Children's System of Care, so we're lucky to have Perform Care. So we can link kids to, if they qualify, quick access to in-home intensive therapy. And usually the first assessment is done within a day or two. And then if they get approved, it's 8 weeks of in-home, free in-home counseling. So oftentimes we'll use that for people who don't need to go to the ER, but need more than what we're able to do in the health center.
Yeah, you guys are the envy of the nation, I guess.
I didn't realize how lucky we are to have that.
Yeah, and what you're saying, I think it makes all the difference, right? From Rick's comment before and others, that we find a lot of difficulties finding services, and with you, the difference with you, right? So I think that's the key.
Yeah, and it's gotten worse lately for us that rather than them mobile going out the same day, now sometimes they're not being able to go out for 4 or 5 days because they're short-staffed and overworked as well. But it's still a great resource for that kind of in between.
Yeah, thanks so much, Sarah. No matter what we discuss, we always end up in the bridge, the bridge to nowhere or to somewhere, like in Sarah's case.
So based on the information that was presented today, I'm curious if it's the kind of thing where I mean, it feels sort of like it's up to the clinic when it comes to kind of 11 and below or 10 and below. It's sort of up to the clinic if the clinic wants to do something, you know, in terms of screening tools, but that there's really no evidence for or against at this point. Am I reading that correctly?
Yes.
Yeah, okay.
Well, I found interesting too that the how that's segmented on evidence for the screening, evidence for the treatment as well, and then the risk factor too. But you know, that also gets my attention about, you know, what do you guys think about that? I mean, what do you do for kids under 12 when they identify depression or suicide ideation?
Hey there, my name is Rachel. I'm at an FQHC in Charlotte, North Carolina. I like that question, but I also feel like it's the same with anyone who might not be up for a regular screening. And if that presents itself, then we screen, treat, assess, do what we would normally do. But then the problem is that it only comes up if the child under 11 or the parent of that child feels it's important enough to bring up. So yes, we will follow the same protocol and be very willing to help and treat suicidality in a younger kid, but we're missing anyone who would normally be caught during a yearly screening at a well child visit or anything like that.
Right. There are some stats about instruments, the assist model similar to ASQ. Anyone can be trained on that. There are also some comments on the PHQ and PSC as well. For us, for instance, we use the PSC as the PSC 17 as the screener, but then that if it shows a positive concern, that triggers the PHQ for us automatically. For instance, in my chart, when the kids come to the well child visit. Rachel.
Yeah, I was just responding to Jenny's comment about, does the PSC 17, is that a depression screener? And I was actually trying to go back on the website to see, did they offer specifics for screeners? But they don't. You might have to dig deeper. I mean, they talk about PHQ-9, the CESD. So I don't know what else quantifies, you know, or what else has been studied as a screener.
Right. The PSC
wanted
has
to-
oh, go ahead.
Oh, I was just gonna, David was offering to talk a little bit, I think, about this survey that he helped to launch at CFHA, which kind of asked about what types of screeners are people using in this setting. And I didn't know, maybe would that be okay with you, Chus, if he spoke about that for a minute?
Yeah, I would love to actually to see that, David.
I wish we'd had this meeting 2 months ago because we got an enormous response to the pediatric section of the questionnaire. 80% of the respondents do pediatric screening. If I can screen share, I'll show you the responses we got. There are many things that came up today that weren't in our survey. So
Sure, will it let you, is it saying it's not letting you screen share?
No, I'm just clicking on it now.
Oh.
Okay. Can you all see that? This is
Yes.
the pediatric, this is the summary on the left of all the responses, both to the questionnaire and to the free text field. So again, I said 80 respondents out of 103. You can see the frequency of the screeners used. Now obviously there are variations on the screeners, which we didn't try to get into. But pretty much the top, let's see, the top 6 run the screener. Where it says other entries, those are the free text field entries that people put in. A lot of people spend a lot of time typing in their favorite screeners. So anyway, so this is the most interesting part, the summary. The rest of it is how we collected different data. So I just present that for your interest.
That's really interesting.
Do we have when people answered this, is this what people are using as universal screening, or like
Yeah, that
these
was my
are just
question.
screeners?
Okay, I don't know whether you took the screener or not, but it was broken down by domains. So we led off with pediatrics, and that was kind of an error in the construction of the questionnaire because people felt obligated to add information to the screening list, not realizing that they would be asked about depression and anxiety and so on later on. So anyway, I just present that because it reinforces what we were saying today for the most part. The PHQA, the ASQ. Vanderbilt was more along the lines of ADHD screening. So that's not what we're talking about today. The PSC and so on.
Are people using the scared for universal screening? Has anyone had success in implement? Because otherwise, I mean, just like, I don't know how people realistically implement separate depression and anxiety universal screening for folks other than using like the PSC 17 and using the PHQA.
We have the PSC 17 for well-child visit that goes automatically through my chart, and if that has a positive, the system pushes the PHQ and GAD or GAD-7. We have the SCARE, but also it's more complicated than the other one. And then if the PHQ has a positive on the suicide question is when we have the ASQ available in EPIC. So for us, all that is embedded into the health record. So it's friendly to use, that's what I mean, and push the image. David, what have you been doing with this data so far? I mean, are you, where,
Well, okay, pediatrics is only part of it. We're preparing an executive summary at the committee level, and we'll review that at our next meeting, mid-December, and then we'll publish the executive summary and selected data to the entire membership, the CFHA membership.
Mhm. I mean, I can see for the ASQ is widely used, right? You have 33 responses for that.
Yes, it is widely used. So is the PSC.
Yeah.
The SSRS was also added by a few people.
Right.
For the ASQ, I mean, I think about that as the suicidality screener, but also there's one called the Ages and Stages questionnaire that's more developmental screener for young
Yeah,
kids. So I didn't know.
I think that's what we had in mind was ages and stages.
Oh, okay.
If there's another screener with the same initials, well, we didn't consider that.
There's a suicidality screener from NIMH that's called the ASQ that some people, I don't know, anybody, is that what folks were talking about earlier?
Yeah, that's exactly what we were talking about. Yeah.
Okay, well, that's a bit confounding. Then we wouldn't know.
Well, I did this
check it
survey and your questions were very specific about what was the screening question about. So you should know if it's the ASQ for suicide or the other one.
I have to go back and look at the actual
Mhm.
questionnaire. I can say that when we discussed it, it's possible that some people were thinking of one and other people were thinking of the other. We would never have sussed that out at the time we were preparing the questionnaire.
I think just this kind of thing though, when you're able to get data around what is everyone using, and I mean I think this type of data is really interesting for research, but also advocacy purposes and policy and all sorts of stuff.
Exactly. That was our intent, and also to set the stage for outcomes measurements. Because
yeah.
Let's see, there's some
Which
other
is a good segue for our next topic, right, Shoes?
Yeah, we are going to touch on that next month because we also shared in the listserv some.
Here,
Yeah.
I wanted to show you something else here. The role of the respondents was mostly BHCs, and of course, remember, these are CFHA people who went to Boise.
Mm-hmm.
Anyway, there's just a ton of information. We're trying to absorb it all now.
That's nice. There's a lot of activity on the chat. I'm going to save the chat, and I'm sure there is a lot there that we can learn. I don't know how to make people unmute and tell us all that, so I'll just save it. But I know we are close to the time, so yeah, next month we want to discuss the outcome measures, and I think it's very much connected to this conversation.
Shoes, did we decide on what the plan would be for next month, or we were going to survey folks today about?
You mean the December? Yeah.
Mm-hmm.
Oh yeah, that's a good question. We would love your feedback on whether you would attend the December 26th SIG meeting, or you would like us to skip the December month. You can start or unmute.
Yeah, normally we have it at the fourth, Monday of each month, but we thought we weren't sure about the 26th.
Yeah, a lot of people are out of office at that day. They are setting that.
Well, whenever we send out the minutes for this, we can send everybody an update on just kind of what the plan is for December then. Does that sound okay? Choose.
That sounds good to me. I hope you all come back for the outcome conversation. And thank you so much all for being here. Any last minute things that we need to say, Matthew and team?
No, that was great.
I don't think so. All right. Well, thank you all so much, and I hope that you have a great rest of your month, and we'll see you soon.
Bye.
Bye.
Bye.